Today's speaker is Dr. Kevin Hopkins, who is a Senior Physician Advisor for the Practice Transformation Initiative at the American Medical Association and Primary Care Medical Director at Cleveland Clinic. Thank you for being here with us today, Dr. Hopkins. Today he's going to be presenting Challenges to Team-Based Care, COVID-19 and Beyond. Again, welcome, Dr. Hopkins. I'm going to pass the virtual mic off to you.
Well, great. Thanks, Brittany. I appreciate the introduction, and it's a pleasure to be with all of you today. Thank you for joining us. So, as Brittany mentioned, we're going to talk about team-based care and challenges relative to team-based care. We're going to talk some specifics about COVID-19 specific challenges. Once we talk about what team-based care is in some general terms, we'll talk about other challenges to a team-based care model, such as those that arise from telemedicine, clinical support staff, physician and provider challenges, patient challenges, and challenges presented by functioning within a healthcare system. That'll be our agenda today and the topics I hope to cover, and then we'll take your questions. So we'll start off by talking in general about what is team-based care. Team-based care, as we've defined it, is a comprehensive approach to healthcare delivery transformation that includes the redesign of in-office visits, the redesign of care that takes place between in-office visits with a focus on population health. The office visit redesign includes delegating and sharing responsibilities, and it includes individual caregivers functioning at the level of their qualifications. It includes an advanced role for empowered medical assistants or LPNs serving as clinical assistant, with additional skills and training, including real-time in-room documentation and data entry support. The in-between visit redesign emphasizes a team approach with all staff working at the top of their skill set and qualifications. Our focus on population health has to do with utilization of system and community resources to achieve and maintain optimal health and well-being of the empaneled patient population. Some more specifics about team-based care. It's a higher efficiency practice model that's designed to improve quality of patient care, increase patient access to that high quality care, gain efficiency in our operating systems, and improve satisfaction and engagement at all levels, including physicians, employees, both clinical and clerical caregivers, and patient satisfaction and engagement. A team-based care model utilizes a team approach in caring for patients. Responsibilities are delegated and shared among capable, trained caregivers, and each individual in the chain of patient care, as I mentioned, functions to the highest level of their training and qualifications. Several demonstrable benefits to team-based care are on this slide. I'll share with you. Cleveland Clinic developed and implemented our team-based care model in 2010 in primary care practices. Since then, it's been adapted to several specialty service lines. Similar models exist in other healthcare systems around the country and in various medical specialties. These benefits that I'll discuss briefly today are reflected in those models. We've been able to demonstrate and show decreased risk of caregiver burnout, which is certainly important in this day and age, improved caregiver satisfaction, improved patient outcomes, and enhanced engagement with our patients. Improved quality measures as well as improved patient satisfaction, increased productivity regardless of the payment model, improved quality of clinical documentation, and we've been able to demonstrate that team-based care is a model which is financially sustainable in any payment model, whether you're in a straight fee-for-service contract or whether you have multiple risk-based contracts, capitated care, whatever the payment model that is predominant within your practice or within your system, or if you have a mix of payment models, it's a financially sustainable model in any of those. So I'll talk briefly through what an office visit workflow looks like for a team-based care visit. For ambulatory office visits, they include really several different distinct stages. There may be some visit prep that takes place before the actual encounter. Stage one, once the patient arrives and checks in and everything is gathering of data. Then there's the physical exam and the synthesis of data, medical decision-making, patient education and plan of care implementation, and then post-visit work that takes place after the encounter. Historically, all of these segments have been the sole responsibility of the physician or APP. Team-based care seeks to disrupt that model and share and delegate responsibilities across a team. In a team-based care model, there is pre-visit work that's largely done by medical assistants. This includes things like pre-visit planning and labs. There's a blend of individual, manual, and automated processes that do this based on practice standards and evidence-based algorithms, leveraging things like computer learning and artificial intelligence to place or pend orders for things like standard lab evaluation for chronic disease management and follow-up. We also address health maintenance topics which are overdue or coming up and may pend orders for things like immunizations or screening tests for which the patient may be due or coming up on due. Our medical assistants prepare a paper worksheet with patient demographics, problem lists, medication lists, and health maintenance for our providers to use during the visit. They review and prep lab tests that may have been done in the interim. Imaging or procedure results will be prepared and available for the provider to review and act on. The previous visit's assessment and plan will be reviewed, and the medical assistants will make sure that things that were supposed to take place since the last visit did actually take place, and if not, alert the provider. They'll also review the chart for significant specialty encounters or interactions that may have occurred since the last visit, ED visits, hospital admissions, other procedures, or items that are necessary for provider awareness or for follow-up. During the office visit, the medical assistants will do the traditional rooming intake of checking the vital signs and gathering chief complaint, reviewing allergies and medications, but they'll also pend medications for refill that are due. They'll help to synchronize those medications for chronic disease medications. They'll address health maintenance topics with the patient and pend orders if the patient's willing to proceed with screenings or vaccines or such. And then they will, based on the chief complaint, select one of our note templates to begin documenting in the documentation of progress note section of the EMR. They'll help with agenda setting, both the care team agenda setting for that visit and the patient's agenda setting, and make sure that those goals for the agenda are realistic for the time that we have scheduled. They'll begin to address and document initial information relative to the history of present illness and review of systems. They may administer pre-ordered vaccines if that's been done ahead of time. They'll think about point of care testing if a patient's coming in with urinary complaints, a urine sample, or palpitations. They may think about and go ahead with an EKG, those types of things based on the provider direction. Then they'll come out of the room after doing that intake and present the patient to the physician or the APP, much like a student or learner would in our clinics. And we've taught our MAs how to deliver that type of oral presentation to the provider. Within the office visit, the physician or provider will confirm the history, make it their own, perform the physical exam, perform the medical decision-making, the articulation of the plan. Once orders are pended for them, they'll review them for accuracy and file those orders and drop charges relative to the encounter for that day. What we want to allow our providers to do is really function at the highest level of their training and competency, and all lesser tasks should be delegated to someone else on the team. Further, during the office visit process, our medical assistants function to assist with documentation and data entry, much like a scribe would. They're present within the exam room during the physician or APP portion of the visit in order to complete documentation of the encounter in real time. They'll help with implementation of the plan by pending orders for referrals or tests. They'll help update the problem lists. They'll provide educational resources for our patients, complete forms, letters, other paperwork that needs to be done, schedule a follow-up visit even while they're still in the exam room with the patient. They'll deliver an after-visit summary with the instructions and ensure understanding on the patient's part, and then they'll offer a warm handoff to the next team member if the patient needs to schedule something else. They'll also drop the charges in the chart for any processes or procedures that the clinical staff performed during that day. Post-visit work for the physician, review of the assessment and plan of the note, closing the chart, filing the charges, as I mentioned, and then following up on any actionable results based on test results that come back after the visit. For our medical assistants, they also review and check for test results that they've been completed, making sure that scheduled appointments actually take place in the future, addressing patient questions or requests for information. And then will they also help us with targeted proactive outreach for patients in between visits, specifically around chronic disease management and health screenings. So I've talked quite a bit about what team-based care is and what that looks like in our practice model. Now I want to get into some of the specific challenges, and we'll start with COVID-19 because that's sort of been on the front of everyone's mind for the last year or so. So we'll talk about some specifics relative to that first. One of the big challenges to operating in this type of healthcare delivery system and patient flow system is the need for physical distancing. Safe physical distancing may certainly limit the number of people in exam rooms just based on the sheer size. In our system, standard exam room size is 10 foot by 10 foot or 10 by 12. And so that allows enough space for essentially 2 people to be in there and maintain 6 feet of social distancing or physical distancing. Certainly we provide masks and face shields and goggles and those types of things to our caregivers, but we also want to be mindful of the need to maintain safe physical distancing. There's also the challenge of the need to sanitize shared tools. So things like computers, instruments, other tools that may be utilized during patient encounters. It's caused us to think about how we do handoffs between one caregiver and another, and information sharing, how we communicate back and forth. Pre-COVID, we would hand the demographic page back and forth, clipped to a clipboard. When you have a worldwide pandemic of an infectious disease, it all of a sudden seems like a bad idea to do that. We would use sticky notes and things like that to communicate with each other about what a patient needs or what exam room they're in, those types of things. And we've had to find different ways to do that, utilizing things like sticky note function within our EMR system and utilizing things like instant messaging features. Co-location is a significant functional advantage for efficiency and communication in a team-based care model. It's certainly been made more challenging by the need for physical distancing. Rapid acceleration and the significant continuation of telehealth platforms for virtual patient encounters will be a specific challenge that we'll discuss and call out separately, but our model was not really optimally prepared for that. And how that would affect our opportunity to use a team-based care model. We'll talk about that more in just a bit. We also wanted to limit unnecessary potential exposure to coronavirus and other pathogens. Even if space was adequate in an exam room or a workspace, limiting unnecessary potential exposure seemed like the right thing to do. When you think about patients who may become sick with COVID and the need to perform things like contact tracing, those types of things, we want to limit exposure as much as possible. And then we wanted to be considerate about how we conserve protective equipment like masks, face shields, gowns, and gloves. And so we had to really think differently about our team-based care model in this new era relative to these specific challenges. I'll talk for just a few moments about the telemedicine acceleration as a specific challenge for team-based care. Certainly, we've all experienced that telemedicine usage and virtual visits have been greatly accelerated due to the COVID-19 pandemic. In March 2020, the Centers for Medicare and Medicaid Services implemented waivers that facilitated adoption of telemedicine visits. These waivers addressed credentialing, payment parity for virtual visits compared to in-office encounters, sites of service, and specific services which were qualified for video visits. Additional waivers were added for audio only or telephone only virtual encounters. Some organizations recognized that patient financial responsibility was a barrier, or at least a potential barrier, to utilizing virtual care and suspended their historical prepayment policies. And some held charges completely for virtual visits. Suddenly, there were multiple allowable platform options with HIPAA waivers and common video chat apps, like some of the commercial ones available on our smartphones. Fear was also a big motivator. People didn't want to leave their homes and certainly didn't want to set foot inside of a healthcare facility. States went into quarantine, schools went to virtual learning, retail stores and other businesses were closed, churches worshiped online, and many of us had trouble even getting a haircut. Public buildings, including physicians' offices and clinics, had to ensure adequate space by lowering capacity, putting markers on the floor, marking specific chairs that could be used. We all learned a new phrase, that social distancing, or later termed physical distancing, that we may not have ever heard before or used. By April of 2020, 14% of all healthcare encounters in this country were taking place virtually. That rate was certainly highly variable, and 14% sounds low to us today, but it represents the highest percentage of care ever delivered by virtual means. And certainly that's not going away, it's persisting. So those were sort of the factors relative to the acceleration of telemedicine. We'll talk about what our experience in our organization here in Cleveland was like, and then we'll talk about some of the challenges that were brought on by this expansion of telemedicine. These graphs demonstrate a few things. The first case of COVID-19 was diagnosed in the state of Ohio on Monday, March 9th, 2020. Over the weekend of March 13th through 15th, our operations team worked countless hours, throwing our standard operating procedures out the window and writing a new script for all of our outpatient practices. Our ambulatory primary care volume decreased by nearly 40%. And virtual visits went from 3.2% on that week of early March, 0.5% of our total visit volume the week before that, to being 61% of our total visit volume literally overnight. In the span of 4 weeks, from March 7th to April 4th of 2020, the proportion of Cleveland Clinic outpatient visits that were provided virtually increased from 2% across the whole of our enterprise to 75%, and to just over 90% in primary care. In May of 2020, we converted to a different virtual visit platform embedded within our EMR system. So as you can see, this shift was seismic. It was game-changing in every single meaning of that phrase. And with that came great opportunity, came a steep learning curve, and came some significant challenges. We'll turn our attention now to those challenges relative to the telemedicine explosion. Not only were there challenges discovered in the conversion to telemedicine, there were some real dangers actually uncovered in that process. Care delivered via telemedicine platforms has been rather limited until the past year and has generally not been included in the same team-based care innovations or process redevelopment as in-office visits. The doctor does it all mentality is no more sustainable in a telemedicine environment than it is in a traditional in-office practice model. Yet we quickly reverted to that mentality when sort of the sauce hit the floor and we needed to do something different. Though it felt like forward movement in many ways because it leveraged technology, in some ways we took steps backward. Everyone knows that it's dangerous to text and drive. When you're multitasking and distracted, your reaction time is longer, your attention is divided, and there's more opportunity for bad things to happen. The same things can happen when our attention is divided when we're taking care of patients. It makes me think of sort of a new phrase that's developed in the literature and medical vernacular, and that's distracted doctoring. Similarly, we're inherently aware of the perils of this time-pressured, divided attention, the risks of skipping steps, taking shortcuts, mistyping or clicking, incomplete ordering or placing the wrong order, documentation inaccuracies, working in the wrong patient's chart, inadvertently sharing protected health information with the wrong patient. These are all things that can happen when we're distracted and shifting tasks frequently and don't have our full complement of team support. Some patient complaints, conditions, and some patients really themselves just don't lend themselves well to an adequate virtual evaluation. There are limitations to care we can deliver well through a virtual platform. There's just some limitations that we can't overcome when we can't physically lay hands on our patient or even see them in their entirety, only from the chest up. So these are challenges that were identified, not just specific to team-based care, but really healthcare in general, that we've had to encounter and engage. I'll talk briefly about some clinical support staff challenges, or sorry, maybe not so briefly, but clinical support staff challenges. Some of those specifics are things like training. Training to work in a team-based care model needs to happen upfront and be an ongoing thing that we pay attention to. Our staff is often working in different areas of the EMR than what they've really touched before. It helps to set expectations up front and maintain those expectations going forward about who does what, where, when, and how. Our teams need help with learning how to set an agenda for a visit, how to choose the right note templates, how to edit those templates for content, how to deliver an oral presentation to a provider, how to access and interface with a health maintenance tool within our electronic health record system, how to pen orders and make sure they're the right orders, what to document and how to put it into the patient instructions section, how to schedule appointments, what our in-basket workflow is, how to fill out forms. All of these things are oftentimes things that we take for granted, but are not insignificant tasks that need to be done. Scope of work, pace, priorities, these are all things that need to be reviewed with our teams on an ongoing basis. Many times the provider will get impatient about how long it may be taking to room a patient while not understanding what's actually taking place behind that closed door. Progress milestones and monitoring need to be considered. We need to think about how we would communicate where it's safe to add a patient on to our schedule if the need arises. Utilize communication tools like team huddles, pre-clinic huddles to review the patients who are scheduled for the day and what the workflow is going to be like. Timing and usefulness of feedback that's bi-directional. And then rules for team communication. Are we going to use sticky notes? Are we going to only communicate verbally? Are we going to use instant messaging? How am I going to let my MA, for instance, know that the patient in room 19 needs a urine sample or needs a strep swab? Ongoing training and education is critical and crucial for the success of a team-based care model. Developing resources that can be used and reused in the future for reference by our teams is also a great way to share and codify our experience and our knowledge. Our medical assistants, our nurses, others that work in our practices are smart medical professionals who can do more than just get a weight and a blood pressure if they really want to, but we need to be engaged in training. We all have a mind to use, and we have an option whether or not to use it to our full potential. For our clinical support staff, there's high potential for much more fulfilling and rewarding work opportunities for skill development and even career advancement. For some of our clinical support staff, perhaps medical assistants, it may just not be in the cards for them to go to nursing school to further their career, yet they want more and can do more. And this is a means for them to advance in their career and personal skills as a result of that. Other things to consider: what happens when there are open positions? What happens when there's turnover in a position? What happens and how do we recruit the right person to fulfill that open spot on our team? What happens when one of us is out, either planned because of vacation or unexpectedly due to illness, or a 14-day quarantine because of a COVID exposure or some other reason? How are we going to pivot and shift our practice model on that day? Are we going to shift to a hybrid model where we sort of do a little bit of standard practice model and a little bit of team-based care? Do we just get the patients in the room and move on and not worry about team-based care and documentation support for today? Those are things that need to be discussed and really understood before it becomes necessity. Some challenges specifically related to physicians and providers. Physicians especially tend to have trouble letting go of control. I know that may be a surprise to many of you, but to some of you, it will not be a surprise. It's a challenge. Physicians especially tend to think less in terms of black and white and more in many shades of gray. So our clinical support staff may want things to be very black and white, but it may not always be that cut and dried or that simple. We may not always be as patient as we need to be. We feel time pressure and the need to move faster. And yet, in our desire to gain efficiency in our practice by training up our staff, we may forego that training in order to do what seems to be simpler or faster in that moment. Trust takes time to build within a relationship, and it really only takes moments to break. Often we think it's going to be faster and easier just to do something ourselves rather than train and retrain and re-educate someone else to do it as part of a team. We also might get frustrated because having another person in the exam room to help with documentation or to be available to help with exams is something that we need to explain to the patient. It requires communication. Change can be challenging and it can be frustrating for both caregivers and for patients. We're also not used to having an audience. And what I mean by that is another caregiver in the room seeing and hearing what we do in the sort of the sacred space of interacting with a patient. So there may be the perceived need or feeling of needing to impress that caregiver or do things differently than you might do otherwise because of someone else being in the room. So those are a few of the challenges that we've needed to think about and communicate really with our providers about how we're going to handle. Some challenges specific to healthcare systems. Most of these related to team-based care tend to be budget and cost related. Oftentimes, our administrators will think about dollars and cents, FTEs, and headcounts, rather than seeing a model of advanced team-based care as an investment with a significant future return on that investment. There are traditions and standards within healthcare systems and practices, such as one physician always gets one medical assistant. And so how can we break those barriers down to create a new normal? Often there's space constraints. Many of our practices just weren't built with team-based care in mind, especially when it comes around co-location of the teams, whether there's a pandemic or not. Regulations and compliance often come up as questions and challenges and barriers to a team-based care model. Often, though, the limitations on who can do what are self-imposed by our practices or our healthcare organizations. Often, for good reason, due to past experience, and certainly when it's a patient safety or caregiver safety issue, those restrictions may be necessary. When you run into the counter argument of, well, we can't do this because of regulatory compliance issues, I found it helpful to say, can you show me what that regulatory issue or standard is and what agency that's from? Oftentimes people don't know where to look, or we find out that it's a self-imposed restriction rather than truly a regulatory one. As we become increasingly dependent on technology, there are questions and sometimes issues with security of that technology and accessibility for that technology. So things like login security into our EMR systems and other things like that that may cause workflow disruptions can be issues for our system administrators. I wanted to share one example relative to the regulatory compliance questions. My practice was fortunate enough to host a learning visit by representatives from the Joint Commission back in March of 2017. I won't take the time to read all of their comments that are shown on this slide, but it'll be available to you. But they watched our process of medical assistants rooming patients, doing the extended intake, beginning the documentation, handing the patient off to the provider, coming back into the room and working as a documentation assistant or scribe, pending orders, populating patient instructions, all of those things we talked about in the workflow. Their feedback was extremely positive, and they were impressed with the capability of our staff and the novel approach to providing care that we had developed and were delivering. They used this to try to think about how they might change some of the standard regulatory requirements that have been in place, many of them for decades, and haven't been updated to be in line with medical practice as it is today, specifically around utilization of a team to deliver care. In a hospital or inpatient or procedural setting, it's not uncommon for many people to be involved in the delivery of care and for there to be multiple handoffs. At each of those handoffs, there is opportunity for a patient safety issue to arise. But if they're done well, it can actually be a very efficient model for moving patients through our clinical system. We should not expect anything different in an ambulatory or outpatient setting. We can gain efficiencies by leveraging the strengths and skills of our team to help provide care for patients over the continuum. I'll talk for just a couple moments about some specific patient challenges relative to team-based care. Some patients are, let's face it, just disagreeable people. They're going to be disagreeable to anything that we try to do that may be different or outside the normal from what they've experienced in the past. So we'll need to figure out how we're going to handle that up front. When I first rolled out our team-based care model in 2010, I decided that if a patient asked for the medical assistant to step out, I was going to handle that in this way. Most of the time I would say, sure, that's fine, and excuse the medical assistant. And then when the patient brought up something that they wanted to talk about without the MA in the room, I would say, oh, is that all that you wanted to talk about? You could have talked about that with them here in the room. They're medical professionals. They've heard all these things before. I know you may feel embarrassed or uncertain about it because it's new or different to you, but to us, this is what we do all day, every day. That helped to reassure our patients. And the next time they were much less likely to ask for the medical assistant to be excused. But there is something to be said about the need to overcome that extra person being in the room and the uncertainty that that often brings for our patients. Some patients will complain either to us or to others that they don't have any time alone with the doctor. And so the way that I communicate that to patients is to talk about the advantages of having another person in the room. It's another set of eyes and ears to make sure that we provide the highest quality care possible and to make sure that we don't miss anything. It obviously can take time to build trust in a new patient, but I've found over time, my patients often, many of them, will say things to my medical assistants that they might not tell me directly. It's another source of history gathering, of collateral information that goes into the overall health picture for that patient. It's important for our patients to understand that it is normal today to have a team of caregivers rather than just an individual performing all tasks relative to their health care. Any change can be difficult, but if it leads to a better process or a better outcome, then it's certainly worth it. Patients are sometimes hesitant because they think they're going to have to repeat their story over and over. One of the ways I've overcome that is when I come into the room with my medical assistant, I'll repeat some of the key history points that the MA shared with me. Patients are often surprised by how much detail the MA shared and what I already know about their situation by the time I walk in the room. It often prevents them from feeling like they need to repeat the story, which then adds more time to the visit. Oftentimes, though, there can also be interruptions in our workflow, whether that's the need to pull a provider out of an exam room or an office emergency that happens that really takes away from what's going on with the patient we've been with. But all of those are, while they may seem like significant challenges in and of themselves, and when taken in individuality, taken collectively, none of these challenges are things that are insurmountable. None of these are things that we cannot overcome with education and with training. It's just we have to take the time and have the patience and have the desire to do it. So I like to use this phrase: team-based care needs to be a win-win-win. It needs to be a win for the patient, a win for the caregivers, and a win for the healthcare system. Either everyone has to win or no one wins. That phrase was given to me by a friend and colleague of mine, Dr. Jerzak from Bellin Health in Green Bay, Wisconsin, who's been a great champion of the team-based care model. And we've both had opportunity to realize and recognize the advantages to this system. It doesn't work for everyone in the same way that it works for me. Not every physician is cut out to practice in this model. Not every medical assistant or LPN or clinical technician is cut out to work in this model either. Not every patient panel or population is right for this system. But by and large, it can be adapted to your practice model. You may not be able to take the entirety of it and plug it in your practice, but you can take component parts of it that make the most sense, where you want and need to gain efficiency, and need help in managing your patient panel. And so I would encourage you to think about parts of the team-based care model that you could leverage and integrate into your practice. Or if you're already practicing in a model that leverages some of these team-based care model principles, I hope you got something out of our talk today in how to identify and potentially overcome challenges when and where they arise. Here are some AMA resources that are available to support physicians and staff in your practices. And that's really the end of my formal remarks today. I can hand it back over to Brittany, and then we will have time to address any questions or comments that you may have.
Thank you so much, Dr. Hopkins. Thank you for sharing our AMA resources. We thank all of our participants for joining us today and hope that you're able to join our next scheduled webinar, which is on April 20th at 11 a.m. Central Time. This webinar will feature Dr. Donna Zollman, who will speak on fostering physician humanism and connection with patients. For general questions or comments, or as I said previously, if there are any questions we're unable to get to today, please email them to the Steps Forward inbox.
Welcome, everyone. My name is Jim Rohack. I'm also a senior advisor with the Professional Satisfaction Practice Sustainability Group, and I'm going to help moderate the questions. There was a question raised in the chat of whether these resources, the links will be available. This recording will be posted and sent a link to all who have registered, so you'll be able to access it that way. So Kevin, if you can put your video back on, that'd be great. We have a couple of questions in the Q&A. You touched on a little bit of the regulatory issues from the system standpoint and used the Joint Commission as an example of them coming in and maybe doing some standards. But another one that's concerning is the scope of practice. So that's under the state medical board or the board of nursing, since many medical assistants aren't really licensed per se. They can get some certification, but not necessarily licensure. So how have you dealt with that scope of practice concerns that may have been raised?
Sure. Thanks, Jim. First of all, good to see you. Can you hear me okay?
Yes.
All right, great. Thank you. So I appreciate that question. So yeah, you're right. There are national organizations that do some registration or certification of AMAs and of MAs, pardon me. The AAMA is one, and you can have certified medical assistants or registered medical assistants, but that's certainly different in the scope of practice guidelines, as you mentioned, are set by the state. So there is some variability in that. So it certainly would behoove all of us to make sure we know what our state requires, what the restrictions are. I'll tell you from working with a lot of healthcare systems, including our own, most restrictions that we place on what our MAs can do are self-imposed. And they're well intended, as I mentioned earlier, for a patient safety issue, but some things really can be overcome. So for instance, in our system, medical assistants aren't able to, traditionally have not been able to do PPD, skin TB testing. We don't do as much of that anymore because of the blood test availability, but that was something that we were able to get our MAs trained and signed off on competencies to be able to do, because it just made sense. If you had a private practice that was outside of our healthcare system in Ohio, that's something your MAs would do. There are a lot of private practices that don't have any RNs or have very limited RN support, or even LPNs in their group. And so, how do they overcome that? So you want to certainly live up to the expectation of the legal ramifications, and also do what's right for patients. And if you can do that with your staff being trained locally, you want to do that. So it really does help to say, well, what is the restriction? Does it make sense for our patient population in our office setting? If so, that's fine. We will continue to abide by that. If it's a self-imposed restriction, is there a way to overcome that through training, education, and competency?
So it sounds, again, to summarize, if you're part of a system, making sure that you have a conversation with your risk manager and maybe your health lawyer from the system and saying, hey, this is what we're planning on doing. to diffuse some of the myths and or concerns that have been raised over time. And so it's helpful to get ahead of the curve. So
Yeah, absolutely. And to expect and anticipate pushback, because
Yeah.
the first answer when you bring up something like this is always going to be, well, no, we can't do that. Goodness.
Right. Do you have any strategies that you have implemented in your system to help promote trust between the physician and the medical assistant?
So as I said earlier, trust can take a long time to build and can be fractured in an instant. So it really does take a dedicated, conscious effort to do that. So a few things I'll say is specifically speaking from the physician side, to continually encourage and build up your practice partners, to refer to them as something like that, teammates, practice partners, rather than a medical assistant or a nurse practitioner, something like that, that really sort of breaks down the hierarchical walls that we have tended to erect in our culture. So build each other up, demonstrate value. So I find great value in complimenting my teammates when they do something really well, and even if it's just a sort of run-of-the-mill ordinary task that they did very well, I want to make sure that I compliment them on that. The other way I've found great value in doing that is to do it in front of patients, and or to do it in front of other folks in our office, other team members, other caregivers, because it really speaks to the value of that individual. To be as transparent as we can with each other on our own team, to admit when we've made mistakes or when we forgot to do something. I think if we as the providers are transparent, it is then more suitable for our staff to feel comfortable to be transparent. We want to build that culture of accountability, and also the psychological safety, where it's the right thing to do to bring up something that has gone awry, or a mistake that's been made, or something like that. I often have thanked my medical assistant and my APP partner for their honesty. It does no good for me to say to my MA, so what was his blood pressure? And she tells me a made up number rather than telling me she forgot to check it. I'd much rather her say, oh, I forgot. And I'll say, gosh, thanks for being honest. I'm happy to do that when I go in there. So I think that really helps to build trust. And then just the ongoing training and support. None of us are in this alone. We're a team. We're in it together, hopefully for the long haul. And we should treat each other as such, just like we would our family.
Right. So a shameless plug, but the AMA Step Forward program does have a nice module on MA education and training. So for those that are watching that may want some additional information, please access that resource. Now, speaking of training, when you're training a new MA, do you have an internal program that you've developed, or are you using external sources?
Yeah, so we developed our own, and then we started with sort of our basic standard training for medical assistants, and spun it up to fit the needs of this practice style. So our training resource manual we shared in the work that the AMA did around developing that Steps Forward module for medical assistant training. So some of the content of that is straight from our training manual. And I know other health systems have done the same. There are third-party outside vendors that will come in and do training for a cost. And so they have training resources available as well. But we sort of developed our own based on our standard MA onboarding and training program.
Okay. So you had mentioned a little bit about the third person in the room concerns. Some of our viewers may be part of academic centers where they've got the medical student, the resident, the fellow, and all of them have to deal with it. So have you had any experience of over fatigue of the patient, or how do you frame that educational environment with the MA?
Yeah, so one thing is to do your best to not make the patient repeat the story over and over, because that's the complaint we always get, right? I've already told so-and-so this. Now, interestingly, and anybody that's gone through our educational and training programs or is involved in them will understand this. The not quite theory, the actuality of attending drift, meaning the closer you get to the attending, the more accurate the information gets. So sometimes the history changes, and that can be valuable. But trying not to frustrate the patient by making them repeat the story over and over again. So going in and confirming the key history points, allowing the patient to confirm or correct anything, and then saying, is there anything that I may have missed or that I might not be aware of?
Okay, great. And then, so did you, in your system, did you have to shut down because of COVID? Did you have a situation where somehow someone tested positive on the staff and you wound up having to quarantine and shut down?
Thankfully, in my clinical office, we did not have that.
Sure.
Certainly, we had it across our system. We never shut down any offices completely. We did, as I mentioned earlier, pivot to almost entirely virtual visits for the course of several weeks to a couple of months. But then gradually, we started getting back to more in-person, in-office visits. And that was one of the big challenges with this team-based care model is how do we go from an in-office visit to a virtual visit and still leverage the same type of team care and handoffs? And it was challenging. And there were some things about our first virtual visit platform that we were using that really didn't support that very well. The inability to hand off a virtual visit from one provider to the other. You had to log off and somebody else had to log on. And if it was after a certain time, you got booted. So the system that we utilize now, we have the ability to hand virtual encounters back and forth among providers in the care team. So I could be sitting in my office and an MA could be sitting at the nurse's station or in a cubicle or an exam room, and we could be shuffling that patient back and forth through a screen, just like we would do in person in the office.
So speaking of emerging from the COVID-19 shutdown, so how are you planning on moving back to the team-based care model with everybody being vaccinated? Are you going to stop virtual visits? Are you going to just go back to the old way? What is your strategy that you guys are thinking about as far as the transition?
Sure. So we had been looking to accelerate acceptance and adoption of virtual visits in our practices in 2019 and early 2020. In fact, I joke sometimes one of our operational goals as a system was to get to 10% of all patient encounters taking place virtually by the end of 2020. Well, that mission was accomplished on March 17th. So yeah. But it's also clear that it's not going away. The need and demand for virtual access is going to remain in some quantity. And so what we're doing now is certainly a mix of virtual and in-office visits, and we've taken away a lot of restrictions, and we're sort of allowing our patients to pick and choose the modality that they feel most comfortable with, as long as it's medically appropriate. Where that's shaking out in our system is about 80% face-to-face in-office visits and about 20% virtual, and it's been pretty steady for about 6 months. So it may continue to shift, but that's where we've landed.
Yeah, I think, and that's about what the national observation has been in primary care, kind of 80-20, but it's also can be incentivized based on the financial barriers that an insurance company sets up. So if they say virtual visit, no copay, but in-person 25, urgent care 50, ER 250, that may continue to incent people to think about, okay, what do I really need? How do I need to access it? What's going to be the best way to get my care when I need be?
Right, and that's sort of the wild card in all of this, right? Because we know that the Medicare waivers were put in place to remove barriers to virtual care. The commercial payers followed suit for the duration of the public health emergency. Once, Lord willing, that ends, what does it look like, and how does coverage change from what it was pre-pandemic? There's certainly a lot of advantages to having patients continue to connect to us through a telemedicine platform, whether you're the patient, the system, or the payer. When it comes to things like facility charges and those types of things, it's a much less costly alternative to an in-office visit.
Right. Have you found that in your population that you're caring for in your clinics that they are in broadband deserts, so that a virtual visit with this modality becomes problematic? They can do a telephone call, but that's not the same as obviously getting the nonverbal. Have you found that there's parts of Ohio and the draw area that you're pulling from, that there are areas where you just can't get a signal and people are really frustrated with virtual visits?
Yes, absolutely. So even on the near west side of Cleveland is a geography and a demographic that doesn't necessarily have access to the same technology capabilities that most of the rest of us do. In mid-northern Ohio is a significant Amish population, and the technology companies just haven't invested in the infrastructure in those areas like they have in others. So yeah, we have that same issue, and we've struggled with how to overcome that, whether it's setting something up in a patient's home so we can do some remote monitoring, those types of things, and we provide the service through a technology alternative or some other means. But yeah, we've certainly experienced that as well.
Well, I think we have now cleared the Q&A and we've cleared the chat. And so Kevin, I want to thank you very much for your expertise and comprehensiveness in the presentation. Brittany, thank you for helping us move this process forward. Again, as was reminded, this will be posted to everyone, so you should be able to get the actual live links to the resources that are available. If not, then just go to the AMA website, ama-assn.org or stepsforward.org. Either one will get you access to the information you need. We wish everyone to have a wonderful rest of your day and look forward to seeing you on a future webinar.